Hey, good afternoon, everyone. I'm Dr. Kanani, the Division Head for Allergy and Immunology here at St. Paul's Hospital and at UBC. And it's my pleasure to introduce Dr. Juan Ruiz. He's one of our recent graduates from the UBC Allergy Immunology program. I graduated in 2021. And shortly after, he joined our division here at St. Paul's. He's also on staff at Vancouver General. During his residency, he actually established the perioperative anaphylaxis clinic at Vancouver General, and he's now the medical director of that. And more recently, he's also established an aspirin desensitization clinic here at St. Paul's Hospital in conjunction with respirology ENT. So his talk today is going to be on NSAID exacerbated respiratory disease. An aspirin a day keeps the surgeon away.
Thank you so much, Dr. Kanani. And my apologies, I was a bit late. Morning clinic was a bit more complex than I thought. So yes, let's get started with the presentation. So in terms of these are my relevant disclosures, which have no bearing on this talk. So the objectives are we're going to understand the classifications of non-IgE mediated allergies to NSAIDs. We'll become familiar with the diagnosis of NERD and explore more of the recent advances in NERD therapeutics. So just to review, there's two types of reactions. You can classify between type A, which are exaggeration of normal pharmacology, and then type B, which are allergy, either IgE mediated, T cell mediated, which are immune, or pseudoallergic, which is through COX-1 inhibition. So these are the 5 types of reactions under the type B classification of NSAIDs, and we'll go through some of the other ones just so you get a lay of the land. So these 3 are the ones that are mediated through COX-1, the NERD, which we'll be talking about today, as well as the NSAID exacerbated cutaneous disease and NSAID induced angioedema. So the first one is called NSAID exacerbated cutaneous disease. Again, COX-1 mediated. These are patients who have recurrent hives. So that's called chronic urticaria. And they'll take an NSAID and their hives get worse. So think about as adding fuel to a fire. They already have the issue with the hives and the hives just get worse. Usually it could happen between 30 minutes and 4 hours of exposure. And you could diagnose it with a challenge, typically treated with antihistamines and sometimes leukotriene receptor antagonists. And in these cases, we avoid COX-1 inhibitors. The other COX-1 mediated reaction is called NSAID-induced urticaria and angioedema. This is similar as previous, but these are patients who do not have a background of hives, but they'll have a reaction when they take the NSAID. It accounts for about 40% of all reactions, non-immune reactions for NSAIDs, and usually treat with antihistamines, and that it's very similar to the previous one. Now, moving to the allergy one, there's 2 types. There's the IgE-mediated allergy, so the single NSAID-induced urticaria, angioedema, or anaphylaxis. So this is, again, mediated through an IgE antibody. These are mediated through different chemical structures. And there is an IgE antibody that is primed from previous exposure on mast cells. And upon further re-exposure, they will have a degranulation and anaphylaxis. Now, I will say this is extremely rare because most of the reaction seems to be mediated through the COX-1 inhibition. Lastly, we'll talk about single NSAID-induced delay reactions. These are T-cell mediated, and the prevalence is unknown. Usually, they have maculopapular exanthems, but it could be as bad as Stevens-Johnson's and DRESS. In this case here on the right is a case report of a man who was bitten by a dog. He took ibuprofen and developed pustules all over his body. So he developed acute granulomatous exanthematous pustulosis, or AGEP, from these NSAIDs. So again, these are more delayed rashes. So that kind of gives you a sense of the landscape in terms of reactions. But now we'll focus on the topic at hand, NERD. So what's in a name? You probably heard about this disease in medical school. It used to go under Samter's triad, previously known as aspirin exacerbated respiratory disease, and more recently changed to NERD to include all NSAIDs. Now, this is a triad of 3 main diseases: asthma, NSAID hypersensitivity, and polyposis, nasal polyps. So let's talk a bit about the history of NERD. So the first cases of anaphylaxis to, or sorry, NERD occurred in 1902. There were several deaths reported in the 1930s and in 1935 when people have severe bronchospasm and cyanosis after consuming aspirin. NERD was initially described in the French literature in 1922. However, it was not translated into English, so it didn't really reach international significance until 1968, with the famous case series from Samters and Beers that documented, the triad. So let's look at some of the data. Usually, NERD tends to be female predominant. About 60% of the patients are female. A lot of them will have 100% of them will have reactions to aspirin and nasal polyps. Some of them will have reactions to foods, particularly high omega-6 foods, and alcohol. About 80% of them will have alcohol reactions when they get congested and bronchospasm. Now, a lot of them will have recurrent operations, about 4 to 5 in their lifetime. So let's dive deep in each one of those triad components. In terms of NSAID hypersensitivity, uh, most of the symptoms are respiratory, about 40 to 88%. So you can expect nasal congestion, sneezing, pruritus, coughing, and wheezing, and shortness of breath. Now, 8 to 20% of the symptoms are non-respiratory, like GI upset, crampy abdominal pain, flushing, urticaria. Now, the tricky part on these reactions is that the onset of symptoms tends to be delayed. It could be anywhere between 30 minutes and 3 hours. Now, there's also a lack of awareness from patients because sometimes they might take an anti-inflammatory and not have a reaction hours later. So they might not be forthcoming about it. Now, there's also a dose-dependent reactivity, meaning that depending on the dose that is given, you might get a reaction. So these are from 2 desensitization papers that were published in the last 10 years. The one on the right shows that only about 9% of patients react to 40.5 milligrams of aspirin. Once you increase that to a baby aspirin of 81 milligrams, about 65% of patients will react, meaning that you might have some patients that could take baby aspirin and still have NERD. Most of them will react after a dose of 325 milligrams. So the dosing is very important as well. Now, what's interesting is that there seems to be a variable response to challenges. This is a study that looked at 50 patients with NERD, and in 28 of those patients, they did repeated challenges. And what's interesting is that they found that upon repeating the challenges, they don't always get the same response. Sometimes they get an asthmatic nasal response, but then several months after, they'll repeat it and they have no changes. This is termed as a silent desensitization. So there's obviously a lot of factors at play in here, but usually the NSAID challenge is the gold standard for diagnosis. Now, let's talk a bit about pathophysiology. How does this work? So the big disclaimer is that it's not fully understood, but what we know so far is that there tends to be damage to the epithelial barrier, either in the nasal epithelium or the lung epithelium, through viruses, allergens, maybe bacteria. But a lot of these patients will have a prodrome viral infection, and then their symptoms usually tend to start after that. You get T helper 2 polarization through activation of TSLP and IL-33. And after you do that, you start creating a lot of the Th2 cytokines, IL-4, IL-13, IL-5. And that in turn recruits eosinophils, mast cells, and you get subsequent release of IgE. So a very T helper 2 heavy response. Now, in terms of the other deregulation, there's deregulation in the arachidonic acid metabolism, which we'll explore on the next slide. So one of the main things that is seen on NERD patients is that they have increased activation of 5-lipoxygenase activity and increased activity of leukotriene LTC4 synthase, which results in increased release of leukotriene or cysteine leukotrienes, which are inflammatory leukotrienes that leads to bronchospasms, increased mucus, and increased congestion. More recently, there's been studies that there's increased roles of platelets in this algorithm. From biopsies of nasal polyps, they've seen that they have these big lymphocytes that are covered in platelets, who are in turn helping this chain reaction of increased cysteine leukotrienes. Now, on the other side, you have the COX-1 and COX-2 enzymes that transform arachidonic acid into an anti-inflammatory prostaglandin, particularly known as PGE2. That one helps with decreased congestion. It can counter the bronchospasm, and it seems to be protective. However, in these patients, they tend to produce less of it. All right. Now, lastly, the PGD2, it's similar to the PGE2, but it's more inflammatory. Now, you're probably at this point a bit confused, so I'll keep it simple. So this is a simplified version of what's going on. So you have the arachidonic acid pathway. You have COX-1 at the top, 5-LO at the bottom. You have the inflammatory leukotriene E4, and then the anti-inflammatory PGE2, which blocks that. Now, on these patients, if they were to get aspirin, you block COX-1. That means less PGE2. That means less inhibition of leukotriene E4. And then you have increased release of LTE4, which results in congestion and bronchospasm. Now, a quick word about NSAIDs. So these are classically COX-1 inhibitors: aspirin, ibuprofen, diclofenac, mefenamic acid, and meloxicam. Now, there's a start on meloxicam because meloxicam tends to be a weak COX-1 inhibitor, but at higher doses, it can activate it. So these are absolutely contraindicated in patients with NERD. Now, Celebrex or celecoxib block COX-2, and these tend to be safe in most patients because, again, they don't block that enzyme, so you don't get the reactions. Now, there's always case reports and exceptions, so we usually recommend to introduce Celebrex or a COX-2 inhibitor for pain, for example, in a patient with NERD in a monitor setting in case they have a reaction. What about acetaminophen? Well, it turns out acetaminophen actually has an acetyl group that has weak COX-1 inhibition. So some of these patients could actually have reactions to acetaminophen, about 34% of them. Usually it's at the higher doses, at the 1 gram dose. And what's interesting is if they have reactions to acetaminophen, they tend to have a lower threshold of reactions with aspirin, meaning when I'm desensitizing them, I would expect them to react at the lower doses. So this is a good way to prognosticate, how they're going to do with the aspirin challenge. So that takes care of the NSAID hypersensitivity. What about the nasal polyposis? How does that present? So here, that's a video of a rhinoscope looking at all the different polyps. They usually present with anosmia, facial pressure, a lot of facial pain and sinus infections. They're quite difficult to treat and require multiple surgeries. And a lot of times they'll require multiple visits to the OR. Oh, sorry, let me try that again. Okay. Anyways, but on CT scan, you can see increased polyposis as well on the sinuses, increased eosinophilic mucin, which is a thick green mucus that gets accumulated on the sinuses. Looks like peanut butter. It's kind of gross, actually. And when you look at it under the microscope, there's a ton of eosinophils. Now, you can see here that patients with AERD, particularly on this part here, they have a lot of failure of their surgeries. So the polyp-free rate after surgery is only 10%. So most patients will have a second surgery about 5 years after the initial one, compared to 84% of control patients, just regular patients with polyps. Now, one thing that's important as well is using scoring systems. We use the SNOT-22 to classify nasal polyposis, and that's one that we'll come back to when we talk about biologics. All right, let's talk about asthma, the third component of the triad. So usually they could present with cough, wheezing, chest tightness, difficulty breathing, and again, they're mostly eosinophilic. In a study by Masia et al. In 2005, they actually found that they had worse FEV1 after bronchodilation. They tend to have more visits to the emergency department, steroid use, and higher risk of intubation compared to aspirin-tolerant asthma. So again, these patients tend to be the more severe asthmatics that you'll see in your practice. Lastly, this is the kind of natural history of what you could expect. Usually, these patients present on their 20s. They'll have a viral infection or some sort of rhinitis that triggers the events, followed by sinus problems like polyps, anosmia, facial pressure, usually, but that tends to be variable. Asthma tends to be developed late, usually 2 years after the initial disease. And then lastly is the NSAID intolerance. Usually, that's the way it progresses. In terms of other things, alcohol hypersensitivity, these patients unfortunately are not able to drink. A lot of them, if you ask them what happens when you have a beer or when you have wine, they'll always tell you they have congestion, coughing, wheezing. So it's a pretty miserable disease and they don't have a lot of fun either. In terms of chest pain, they have a lot of chest pain, particularly associated with NSAID desensitizations. Some of these chest pain can be associated with coronary vasospasm in eosinophilic coronary artery disease, but sometimes it could be pleuritic in nature. Other side effects include hearing loss from polyps in the oral area and food intolerance. So patients sometimes react to high omega-6 fatty acids like egg yolks and fried foods. In terms of the epidemiology, it's about 0.3 to 2.5% of the population, mostly adults, and like I said, mostly females. It's very common, actually. So you think about it, 7% of all the asthmatics will have NERD and about 14% of severe asthmatics. In chronic rhinosinusitis, somewhere between 10 to 15% of patients will have it. And it's estimated that there's about 1.5 million NERD patients in the United States. Using those percentages, we estimate there might be somewhere around 20,000 patients with NERD in BC. Now, there's also cases of pediatric NERD. This is a case series out of the Brigham Women's Hospital, and they found 6 patients between the ages of 6 and 15 that presented earlier in their teen years. The disease appears to be the same and responded well to biologics, but also to be aware of that in some cases it could present early on. So in terms of the diagnosis, it's a clinical diagnosis. You need all 3 criteria: asthma, polyps, and a reaction to NSAIDs. Now, it could be a historical reaction when a patient tells you that they've reacted, but a lot of times patients haven't taken aspirin in many years or an anti-inflammatory in years. So you might need to do a challenge to confirm the diagnosis. On the right there, you can have all the different protocols for challenges or desensitizations. It's pretty much the same procedure. The difference with a challenge is you're just trying to diagnose if they have this, versus desensitization, you'll keep them at that dose ongoing for treatment. The one that I use here at St. Paul's is the Brigham Women's Hospital protocol, when we increase the dose at every 90 minutes. All right. Now, this is from up to date in terms of how do you approach a patient with aspirin allergy in your practice, particularly if you need to start aspirin acutely, right, for cardiac protection. Big thing you want to rule out, do they have NERD? Is there a history of asthma, polyps, or like bronchospastic reactions with NSAIDs? Usually, if the answer is no, then you can just challenge them and pre-medicate them with antihistamines. If there is a possibility of NERD, then probably good to give them montelukast or a leukotriene receptor antagonist. And again, give them a small dose separated by at least 90 minutes. Now, like I said, about 60% of patients will react to the aspirin. So even with NERD, some patients might not react at this dose. Now, the one thing I want to make a note of is there's a lot of data on aspirin desensitization in cardiac patients. I know that there's a protocol that is used in the CCU here. These are 2 different populations, right? Cardiac disease affects an older population with different risk factors, while NERD patients are younger, typically healthier patients from a cardiac perspective, right? So that's why the protocols are different. Lastly, diagnostic testing. There's a couple of blood tests that could help, or urine test. FeNO during aspirin desensitization could be helpful if you have an increase in FeNO. However, that's difficult to get because it's not covered by the province. And in the past, I used to get urinary leukotriene E4 levels on the urine. This is helpful in cases where you don't want to do a challenge, you're highly suspicious of the disease, and you just want to know if they have it. So in the past, we were able to send those to the Mayo Clinic, but lately I've been getting my applications rejected, so I haven't been able to order it. All right, so let's talk about management. Now that you know the triads and the symptoms, how do we manage it? So we'll start with lifestyle. There's some evidence about a low omega-6 diet with high omega-3 fatty acids This is a study out of Brigham's with 10 patients. It was a 2-week study where they would decrease omega-6 fatty acids like fried foods, butter, egg yolks, and increase fish oils, vegetables, flaxseed. And then they checked their ACQ scores, SNOT-22, and inflammatory markers. And what you can see over here is that they are actually able to prove that there's a decrease on the LTE4 prostaglandin. There's an improvement on ACQ scores as well as SNOT-22 scores, which was quite helpful. So that's something that I recommend in many of my patients. Now, the proposed pathophysiology is that omega-6 fatty acids may stimulate the arachidonic acid pathway, which then results in more leukotriene E4. So if you're able to have less of the omega-6 and more of the omega-3, that seems to shift things in a more favorable light. The other diet that has some evidence is low salicylate diet. This is a study of 30 patients, a single blind crossover study over 12 weeks. They had issues with compliance and did not check biochemical markers, but they also saw improvement on ACQ7, Lund-Mackay score, and SNOT-22. Here, you can see how the protocol was done, but overall, they did see some improvement on the similar markers as the previous study. Now, for me, I'm not a big fan of the low salicylate diet, mostly because it's an unclear mechanism. Salicylates don't have an acetyl group, so they don't really activate COX-1. So I'm not exactly sure how they would affect this mechanism. Also, in the study, right, there's the issues with compliance, and they were not able to prove that there was a biochemical change, which was helpful on the omega diet. So I usually don't recommend the salicylate diet as much. All right, let's talk about steroids. So steroids are the main key of treatment. Nasal steroids, usually with large irrigation. Pulmicort nebules are very good. They get deep into the sinuses. We're having a shortage right now, so I've been compounding mometasone into salt water, which works really well. Of course, in asthma, ICS and inhaled steroids are very key, usually combined with a long-acting bronchodilator. And oral steroids are the last resort. In some patients, we have to keep them on chronic steroids, unfortunately, because we're not able to wean them off. I would like to talk about steroid bioavailability, and I think it's important to keep in mind. Now, there's some steroids that have high bioavailability, like triamcinolone, beclomethasone, and budesonide. While some of the newer steroids, like fluticasone, mometasone, and cyclesonide, tend to have less bioavailability. And I think this is important as we're dealing with patients who have both nasal, high level of nasal sprays and inhaled steroids, as they likely will have an increased burden of steroids. So it's important to consider that, and it's also important to consider what other medications they're on. If they're on CYP3A4 inhibitors or antifungals, they could have side effects, right? Increased side effects from their nasal steroids. All right, let's talk about leukotriene modifying disease drugs. So the main ones is the 5-LO inhibitor, which is not available in Canada, called Siluton, and montelukast, which or singular, which blocks the cysteine leukotriene receptors. So there's a survey study from Scripps Clinic that showed that 88% of patients tried montelukast, but only 15% found it effective. There's also the increased black box warning that show that there's neuropsychiatric side effects, such as depression, suicidal thoughts. So something to be aware of when you're prescribing it to patients. In this study, this was a 4-week double-blind placebo-controlled trial when they have patients with NERD start on montelukast, and they saw a significant improvement on their FEV1, peak respiratory flow, decreased use of beta-2 agonists, and decreased night awakenings. However, the study is pretty short. So usually in these types of studies, you want to go a bit longer, usually at least 6 months, so you see if this is a sustained response. In a clinical experience, I find that there's a group of patients in which montelukast works, but a fair amount of them, as I show you in the survey, don't find it that effective. Now, in terms of 5-LO inhibitors, they're not available in Canada. In the survey on Scripps, they found that 24% of patients tried it, so not a lot, but 28 found it very effective. Now, the 5-LO inhibitors are very expensive, and you have to monitor liver enzymes. They also are very large pills, so they're difficult to take. But they also are helpful when you get some of the GI side effects during desensitizations, and they can help with some of that crampy abdominal pain that patients can get. Now let's talk about surgery. How do we approach that? Let me see if I can play the video. Yeah, so that's courtesy of Dr. Tambu. He's the surgeon who created the clinic with me. You could have a full lecture on surgery, but just the basic part is we consider surgery when medical failure, when there's medical treatment failure, which is most common in all patients. The idea is to open up the sinuses, take out the polyps, and create large holes so you can get the irrigation in there. So here, I believe he's opening up parts of the frontal sinus and as well as opening up some antrostomies to again get more of the steroids in there. Now, there's different types of surgeries, and that's why it's important to have a good surgeon on your team that could actually help you decide which surgery is the best for NERD patients. There's evidence that draft 3 surgeries and more aggressive surgeries are actually better, but again, they also come with side effects as you're opening up more space inside the sinus cavity. Now, let's talk about aspirin desensitization. So, usually the way it works is we start with small amounts of aspirin every 90 minutes or every 3 hours. I usually use the 90-minute protocol. And we do a spirometry after each dose. You'll be surprised about the lack of awareness of patients and their FEV1. Sometimes they could drop by 30% and they're still talking to you. So you want to make sure that you check the FEV1 before the next dose. Now, in terms of the reactions, we talked about that before: congestion, itchy nose, sneezing, and bronchospasm, as well as some of the GI ones are less available now. There's a pre-medication. I typically use Montelukast for a week before or prednisone to prevent major reactions. And after you desensitize, they need to take their aspirin ongoing, which means that once you start on it, you have to stay on it. If you miss more than 2 days in a row, unfortunately, you have to repeat the whole process again. So that's why it's a very challenge. You have to select the right candidate because you don't want to spend all this time and have them call you a week later that they stopped, right? So I think that's very important. Now, this is from the De Gregorio paper in 2016 that first described this protocol. They have one patient that out of 61 patients, they have one patient that actually had no reaction, one of those silent desensitizers that I told you about earlier. Most of their people, about 50%, had nasal-ocular reactions, and the other 50% had bronchospasm and nasal reactions. In terms of the other reactions, about 23% had dermatological reactions. 23% had GI reactions and 18% had dermatological reactions. Now, only one patient had to discontinue because of the GI reactions, but everyone else was able to complete the desensitization. But just to give you an idea, this is a procedure that takes about 9 hours. So again, very labor intensive. Now, in terms of the evidence, when you look at aspirin desensitization, there's a lot of studies, but most of them are low quality studies. They're usually single arm, no control case series. This is a meta-analysis that looked at 5 RCTs on aspirin desensitizations in NERD and pulled them together to see what the effect of aspirin desensitization is. So those are the 5 studies that put on the table there. The first thing that comes to mind is that there's different doses used. So as part of the heterogeneity on the field, some of the studies use the higher dose of 1,300 milligrams a day for aspirin, which is the highest dose. The other 2 studies used 650 milligrams a day. And then one of the studies used a low dose of 100 milligrams. Unfortunately, we know that the 100 milligram dose is not effective. Anything below 650 a day is really not useful. Now, that's unfortunate because usually we like to do the desensitization right after surgery. You clean up the polyps, you have this nice honeymoon period when patients are doing well, and then you start the aspirin. But the only study that actually did the desensitization after nasal surgery is the one that had the low dose. So that's important to note. So what did they see? Well, they saw that there was an improvement on the SNOT-22 score, which is the nasal score of 10 points, which was significant for aspirin compared to placebo. They also noticed an improvement on respiratory symptoms as well. And they noticed here on the right, you can see that in the regression graph, they saw there's a dose effect. meaning that the studies with the higher doses tend to do better versus the study with the low dose didn't do as well. So again, it shows that dose dependency effect of aspirin in these patients. Now, in terms of side effects, and this is the big crux of the matter, there were a significant amount of side effects, particularly gastritis was reported, and that and GI bleeds resulted in some patients ending the aspirin desensitization. So what does that mean? What are the numbers? So the numbers reported on this, they say there's about a 10-point improvement on the SNOT-22 score with a number needed to treat of 5. Gastritis was the major side effect, and the number needed to harm was about 12. Now, they noted 2 patients who had severe GI bleeds had to stop in one of the studies. Now, one of the things that I found a bit peculiar is that there was no use of PPIs. Usually, most of the groups in North America, we use PPI prophylaxis while the patient is on high-dose NSAIDs. So that's one of the things that I think maybe contributed to some of this high level of gastritis and side effects reported. However, once you add a drug as a PPI indefinitely, as these patients will be on aspirin for many years, you also then have to account for the side effects of that, because we know that PPIs are also not benign in the long term. So again, the rates of gastritis seem to vary across the studies. Now, why do we care about aspirin desensitization? Well, it's mostly a cost. It's a very cheap procedure compared to some of the biologics, and it works well. So in this study, they looked at patients with NERD, and they looked at the cost of therapy after 10 years. You can see with standard therapy, the cost is somewhere about $53,000 in 10 years. Now, the revision number of surgeries is 2.25. If you desensitize patients, usually the cost goes slightly lower by a few $100s, but the revision surgery rate drops to 2.02. Now, if you compare that to biologics like Dupixent, so in patients who did aspirin desensitization and failed and then starting Dupixent, the cost more than doubles from about 53,000 to 121,000. But if you look at the revision history, it's quite low at 1.68. And then lastly, the patients who were on dupilumab the whole time, even before surgery, they did the best with the least amount of surgeries at 1.51 in terms of less revision surgeries, but the cost was almost 185,000. So in a publicly funded system with many patients not having private insurance, there's still a big role in terms of cost for aspirin desensitization. So now let's talk about biologics. So this is, the main biologics that are approved for NERD. So you have dupilumab, which is an anti-IL-4 alpha receptor antagonist. So it works here. You have mepolizumab, which blocks IL-5, so mostly an eosinophilic blocker, and omalizumab, which blocks IgE. Now, for them to be approved for for them to be used on NERD, you need to target 2 things: nasal polyps and asthma. Now, the new biologic on the block is tezepelumab, which works out here on the TSLP. But unfortunately, that one, not unfortunately, but the studies are ongoing for the nasal polyposis. So we don't know if they will. We know it works in asthma. We just don't know if it helps with polyps. So dupilumab, as I said, it blocks IL-4 and IL-13. The main studies are the Sinus 24 and Sinus 52 for nasal polyposis. And I have a graphical abstract here of a sub-analysis. There's unfortunately no phase 3 trials for just NERD patients, and all of the data comes from the sinusitis papers in terms of subgroup analysis. But in this paper, they took about 700 patients from Sinus 24 and Sinus 52, which are both 24 and 52-week studies, and then subdivided them into NERD and non-NERD sinusitis. What they found is that the baseline severity of disease was actually quite high on the NERD patients in things like total symptom score, Lund-Mackay score, and other different measures. The efficacy was very effective in both populations, but they found a significant improvement in certain scores, like the SNOT-22 score, the total sinus score, and the nasal congestion score. And that's some of the bases in which it's argued that dupilumab may be a better biologic for these patients. Now we have to talk about side effects. And the big one that's coming to mind is the increased report of arthralgias. About 4.7 to 7.4% of patients recorded arthralgias or enthesitis during the sinus studies, compared to 1.3 in placebo. This is a case series that looked at 8 patients out of 160 people cohort with NERD, and these 8 developed either arthritis or enthesitis after using dupilumab, usually about 7 months into the treatment. They were treated with COX-2 inhibitors and steroids, and 5 had a spontaneous resolution, so the symptoms went away, but 3 continues to have symptoms. But all of them continue to stay on dupilumab because it's helped them so much with their NERD. Now, there's several unknowns in this. One is that these patients were not seen by rheumatology, so there was no formal assessment. One of them had an elevated ANA, but not all of them were checked for that. And there was an increased eosinophilia in some of them. So I think we're still not sure why this is happening. One of the hypotheses is that there might be a shift on the immune system. If you block T helper 2 responses, you might switch to a more T helper 1 or T helper 3 response. So that's called the escape hypothesis. But again, this is something that we're seeing more often and something to keep an eye on. Now let's talk about mepolizumab. Again, blocks IL-5, blocks eosinophils. This is the Synapse trial. It was a 52-week study. Had 400 patients, about 200 patients had MEPO versus the other 200 had placebo. Again, significant improvement on the scores. They used the visual analog scores for polyps, and you can see that there's significant improvement. Also, you can see they have a Kaplan-Meier graph here in terms of surgical failure and return of polyps. And you can see that there's significant improvement in those who are on mepolizumab, requiring less surgeries. Side effects, headache, pharyngitis, and arthritis. Now with omalizumab, it blocks IgE, so it targets mast cells. So the main studies are the polyp 1 and polyp 2. What's interesting is that these studies are quite short. They're only 24 weeks compared to the 52-week studies for the previous 2 biologics, but 130 patients on each arm. There's improvement on, again, outcomes like the SNOT-22 patient scores, as well as decreased surgery. But usually the surgical scores are more impressive when you look at them for, a full year. The dosing is weighed on IgE levels and weight. And the advantage of omalizumab is that is a biologic that we know for a long time, and we know is quite safe. Now, this is a picture from the actual paper, which I found interesting. And you have to be careful when you look at some of these biologics brochures and papers. In this one, they show you omalizumab or Solar blocking IgE and blocking the mast cells. And then you can see that the mast cell is producing a lot of these inflammatory cytokines, like IL-4, IL-13. And it's a bit misleading telling you that maybe the mast cell is the most responsible for creating these cytokines. However, IL-4, IL-13 were produced way earlier on the ILC2 cell. So again, very important to understand where these cytokines come in play. All right, so the same group that did the meta-analysis for the aspirin did a similar meta-analysis for chronic rhinosinusitis with all biologics, and they also had a subgroup analysis of the NERD patients. And then they nicely tabulated it into a table to show the improvement. Now, of course, with meta-analysis, you always have the risk of bias, and you have to be careful in the way you interpret it. But the results showed that dupilumab had improvement among more domains. The SNOT-22 score, visual analog score, increased improvement of smell, less use of oral corticosteroids, less use of surgery, and nasal polyp size, as well as CT scores. Omalizumab had improvement in 2 scores, and mepolizumab had significant improvement in 1. Now, ASA desensitization, as I said before, there was some mild improvement on the SNOT-22 score, better with the visual analog score. There was some decrease on polyp recurrence. But when you compare it to the biologics do a lot better. Now, the part here on the red is the side effects, as we talked about, the gastritis, the GI bleeds. Obviously, the side effect profile of the biologics is better tolerated. Now, I did show you the arthritis data, and I think some of these biologics are fairly new. So again, as the post-marketing studies extend to 5 and 10 years, we'll get a better sense of what the adverse events are. But again, something to keep in mind of an aspirin desensitization is choosing the right candidate. So the last thing I want to talk about is about confusograms. I show you a lot of pathophysiology. I know it's can be overwhelming when you see that, but you have to think of it as a language that is important to master and to understand, right? When you go to Mexico on vacation, you might know how to say you want to get a taco, right? Or maybe you want to get a little cerveza, or maybe even where the baño is. You might know small phrases, and that might be the level of understanding of cytokines that you may have. But eventually, you want to work it up to be able to read, a full page of, a popular novel like Don Quixote de la Mancha. The bottom line, I think, is as we're moving towards personalized medicine, I think it's very important to spend the time to really understand these mechanisms, because they'll become increasingly important in routine clinical practice. And I think that's a pathway to talk about the future. So where are we going? So these are some of the targets that have been selected. There's some papers that have shown improvement in some 5-LO activating proteins. The platelets, there was a study with prasugrel, platelet blocker, that actually showed improvement in a subset of patients. Again, not everyone responded to that. And they just finished a study on ifetroban, which is a thromboxane receptor antagonist, again, targeting those platelets. And then the platelets, perfect. The last thing I want to say is there's a lot of heterogeneity in diseases that we thought we understood well. I've been telling you this whole talk that this is a Th2 disease. I've been talking about eosinophils, mast cells, IgE. But in this study, they looked at clusters of cytokine signatures. And what they were able to find is that different clusters of cytokine signatures have different prognosis. So they found a cluster of patients with NERD that had low cytokine signals all around. Then cluster 2, that's the classic, elevated IL-4, IL-5, IL-13. And the last one was the mixed cluster 3 that had high Th1 and Th3 cytokines like IL-17 and interferon gamma. What was very interesting is that you can see the time for polyp regrowth in months, that the mix, non-Th2 group actually did the worst. Almost 100% of them had polyp regrowth within a year. The cluster 2, which is the eosinophilic atopic one, didn't do so good, but did slightly better than the type 3. And then the cluster 1 with relative low inflammation did the best. So as you start seeing these patients, you definitely see the heterogeneity of some patients actually respond well to surgery, and you desensitize them once and then they're fine, versus other ones that you desensitize, they fail, they go into one biologic, they fail, you go into the next. And I think that's what we're hoping to eventually accomplish at the AERD clinic. So the AERD clinic was created by myself and Dr. Tambu. We went with AERD instead of NERD just because it has a nicer ring to it. That's me at the front, and on the back with the black scrubs is Dr. Tambu. This is our first aspirin desensitization patient. We started in November 2021, and we run once a month. It's a multidisciplinary clinic that provides aspirin desensitization, surgical consultation, and assessment for biologics. These are some of our 2 more successful stories of people who have done really well with aspirin desensitization, and we were featured on the daily scan to highlight some of the accomplishments of the clinic. So if there are any patients with NERD that are not well controlled that you think would benefit for being seen at our clinic, happy to see them. Our referral form is on CST and Pathways. So lastly, I'd like to give a special thanks to the Department of Medicine Innovation Fund. They've been very helpful finding us a business analyst and helping us with the whole process of establishing a new clinic. The Sinus Center, Dr. Tambu, Dr. Javer, and Anastasia, as well as the Respirology Department. Special thanks to Dr. Apperly and Ali Robertson for all their support in the area and help with the spirometry, as well as the RTs. Of course, Dr. Kanani with his support in the division of allergy. So that's all I have for now. Are there any questions? Anything you guys want to talk about? All right, perfect. Yeah.
That was excellent. So I'm just wondering, in terms of pathobiology underlying NERD development. Do you think that there is a component, especially given that these patients tend to more typically present in adulthood, do you think that there's a component of environmental exposures that are actually contributing to the development of
NERD.
their asthma as well as their nasal polyposis and continued exposure to like omega-6s
Yeah.
in their diet and low exposures to NSAIDs that are actually triggering worsening of that throughout the course of their early lifetime to the point where they get so severe that they present later?
Yeah, great question. I'll repeat it for those of you in Zoom. So are there any environmental factors or other external factors that are triggering or making this disease worse? Yes, most definitely. From a genetic perspective, there's polymorphisms that have been associated, and of course, other external factors. So yeah, we know for sure that viruses and bacteria tend to do activate this Th2 polarization and ILC2 activation. In terms of pollution and other things, that's interesting. I haven't seen literature on it, but I could speculate that probably. I mean, we know that just from the allergic rhinitis literature, when you have combination of soot and carbon, small fibers or pollution in pollens, there's an increase in uric acid in the nasal mucosa and increased immunogenicity. So of course, I would expect the same. In terms of the omega diet, we definitely eat too much omega-6 in North America. And that's been across, you can see this shift towards omega-3 diet, not only in NERD, but many cardiology and different societies have started to recommend that. Because obviously, if you're triggering the pathway on that level, you'll get more of the inflammatory leukotriene E4. So certainly, I think it's a lot more research to be done. I know that you're a local expert on environmental and ILD exposure. So I think that's something that be worthwhile exploring, because I think the short answer is we haven't really studied it, but I'm very suspicious there might be an environmental trigger in some of these patients. Yeah.
And just a quick follow-up with that, has there been any incident studies globally that have compared dietary practices and incidents of AERD?
Oh, that's an excellent question. None that I'm aware of. The problem with NERD, it's tough to estimate, because if you were to do ICD codes, right, a lot of them are not labeled. So you have to, because I tried to get the actual incidence here in BC and it was tough. Then you have to include different things, right? But I think that would be a good one to see, like especially in the Mediterranean, right, to see if there's less of that. But as far as I know, I haven't seen those studies, but very interesting. Yeah. Thank you, Jill. Hello.
So thank you for the talk. A question and a comment. So the question is, you mentioned that sometimes the diagnostic test actually isn't the diagnostic test.
Yeah.
So how do you make the diagnosis if you don't have a diagnostic test?
Yeah. So, I mean, it's rare, but it does happen. So the diagnostic test is the aspirin or like a reaction to an NSAID. A lot of times you can do that in historical, in terms of previous reactions. If someone's coming in with asthma and nasal polyps, right, and they've reacted to an NSAID before, if I challenge them and they already desensitized and they don't have a reaction, I still know that they've reacted before. So you just need to have one previous documented reaction to do it. Yes, the diagnostic test is not perfect. I think 14% of patients will have a silent desensitization. At this point, some groups talk about repeating it. So doing multiple challenges to see if you can get a positive one. Yeah.
So the comment I have is that it seems that even in a clinical situation, you react within a half an hour or 3 hours or 4 hours.
Mm-hmm.
But that suggests that nothing happens in between those times, that you're not exposed to anything in an environmental factor. And it seems, therefore, I guess, comment and question, in all patients who have asthma or nasal polyps, why wouldn't we recommend omega-3 diets, avoidance of non-steroidal anti-inflammatories forever?
Mm-hmm. Mm-hmm. Yeah. No. Yeah, no, that's an excellent question. So, in terms of the asthmatic patients, I don't know the data on omega-3s if that's helpful, but obviously, there's not a lot of harm in eating healthier and eating more vegetables and fish oil. With the anti-inflammatories, obviously we use them for pain, right? So it's nice to have in terms of people with arthritis. So then there's a lot of patients with asthma, polyps, who are aspirin tolerant, who never had a reaction, right? And they've tolerated it in the past multiple times. So I think the likelihood of them having NERD is lower. I think it's tough to put the label, because once you put the label on someone in NERD, you know that these patients are going to do worse, right? We know that they're the ones that have recurrent surgeries, recurrent asthma attacks. So I think it's important to delineate the different populations. There's a lot of patients, with asthma and polyps that might need NSAIDs. And I'm not sure if telling everyone, like, okay, just avoid it, because especially if you never reacted and maybe they had ibuprofen last week, right? In those sense, it's very clear that it's not NERD, and they've never had a reaction. It's unlikely NERD. I do have this slide, and I think that, let me see if I can go back, about the timeline, right? Sometimes it's also important to know how long they had the asthma and the polyps, because it's usually about 10 years. I can't find it. It's usually about 10 years before they get the aspirin problems, right? So you have someone who's had asthma their whole life, polyps their whole life, and you're seeing them and they're 60 years old and they've had NSAIDs before. Again, very unlikely that they're going to now develop ARD. But if someone is in their 30s and 40s, the disease just started and it's evolving, I think that's a different population, yeah. So you have to also kind of keep into account the clinical course, right? Yeah.
And that's my point. It's the younger person who actually hasn't developed the problem.
Yeah.
Would probably benefit the most.
Yeah.
From the prophylactic or the lifestyle changes.
Yeah.
Which would include avoidance of certain things. And
Mm-hmm.
I think it's really challenging and interesting, because I think what you tried, most of us wouldn't even have, not allergy and immunology, but it's not really on anybody's radar to even talk about these things.
Yeah.
And lifestyle modification.
Yeah. Oh, thank you.
So 2 questions. One is NERD more prevalent in people that have severe asthma or quote unquote poorly controlled asthma, or not?
Yeah. So usually they are, I mean, it's chicken at the egg, right? So you look at severe asthmatics, 14% will have NERD versus just regular asthmatics, about 7%. So I guess it's like if you have a severe asthmatic, your likelihood of having NERD is higher. Yeah.
So my second question, kind of related to that, is, most of us it's easy for us to ask a patient, do you have a bad reaction to aspirin or NSAID? But in those who say no, but have poorly controlled asthma, with that history, how many of them actually have NERD, or how many of them would actually have improved asthma control if we treated them as if they have NERD?
Yeah, that's
so how reliable is the patient self-report that I'm okay with NSAID?
Excellent question. Yeah, not very reliable. So, at our clinic, we actually have to hammer it down, right? To say, okay, well, have you taken aspirin? No. Ibuprofen, naproxen, diclofenac, right? And then really hammer the names, right? And the timelines. How long ago was that, right? The other thing that's helpful is some of the other adjacent reactions, right? Do they have reactions to alcohol, for example, right? And do they have reactions to acetaminophen, right? Have they reacted? So I think trying to tease it out, it can be hard. And that's why eventually in some patients we bring for challenges. So to confirm, right? To see, do they actually have this disease or not? Again, there's the limitations of the challenge in the sense of sometimes you have a negative one. Yeah.
So sometimes we know why they're poorly controlled, like they still smoke cigarettes. But if let's say they're well treated and we don't know why they're poorly controlled, is that a good person to refer to you to see if they have this problem?
Yeah. I think if they have polyps and uncontrolled asthma, I think it's good to be assessed for sure. Yeah. Because certainly if they're young, they might be on the spectrum when they're developing. And I usually like to follow them once a year to check in. Because the one thing that I did not show you, some of these guys have eosinophils of 1,000, right? So it's very high levels of eosinophilia, high levels of inflammation. That is nice to keep someone kind of following them. So yeah, I think if you have someone young who has difficult to control asthma, polyps, the history of the NSAID is not clear or they don't report, I think it's still important to send them and have them assessed. Yeah. Perfect. Thank you, everyone.
Yes, I am. Yeah, I mean, my research is primarily focused on inflammatory other areas. So I just joined the
Yeah. Oh, thanks. So thirsty.
Wasn't successful.
Was that?
It wasn't successful.
What?
Patient got wheeled off to get a
Okay.
renal biopsy. 10 minutes before I got there.
Okay.
I might.
Yeah.
We'll see how today's the afternoon goes. He's probably still up there. Like the nurse said, they're going to take at least another update. At least.
Let me see a schedule. Well, let's see a schedule.
So I was thinking maybe I'll just like call the patient first, see, and then the remaining will be a physical exam. Yeah.
How about you stay? That you can get home from here?
Okay, I mean, yeah, I can get home, but it's like I'm gonna be missing out.
It's up to you. I just feel bad. If you wanna come,
How about I call the ward? Because I don't know if he's getting sedated or not. 'Cause,
yeah.
like,
Because I mean, but it's also kind of tough, right? Because we have to be in clinic at 1:30.
and then
And-
leave at 3 o'clock to see the consult. Let me ask him. Let me ask him.
Yeah.
Sorry, this is.
It's up to you. Like,
My focus is kind of a bit more on.
Hi, my name is Kevin with Allergy. Could you please connect me to 5 Bravo, please?
Trying to initiate kind of a wildfire action
Thank you.
plan for our population.
Sorry.
no worries.
The guy really needs a real. Hi, this is Kevin with Allergy and Immunology. I'm calling in regards to, I think, the last name, Bauda. I might be saying it wrong. Yeah. Do you know roughly if there's any updates as to when he's coming back and if he was getting? Yeah.
Thank you very much.
I'm glad that we can share more about it.
Because we always come across people that
Oh,
are.
great. Okay, I will go up and check.
Super,
Is he?
Yeah,
is he-
you don't have a question or you just need to actually challenge them or dig a little deeper,
Great,
right?
amazing. Thank you so much. I'm with the allergy team. I'll be there about 5 or 10 minutes.
Yeah,
Thank you.
the omega-3 is the one that I usually like. The omega-6 and omega-3, they have a nice handout that is
But it's all that, broccoli is,
Salicylic I'm not as big as well.
be careful.
Yeah.
Guys were like bigger.
Back then, yeah.
The evidence. Okay.
Yeah.
So it's not the
Yeah.
diet, it's more the.
Is there some overlap? Some of them, like, for example,
Yes.
avoid, like,
Well, hopefully I can
nuts,
also
right?
give a grand round.
So I think it's maybe on the solution there's some overlap. The omega
Lovely.
chemical too,
Yeah.
which is helpful and a
So
part of
biggest
it.
evidence of what omega-6.
Good to see you.
Hi,
How are you?
how are you?
Thanks so much for coming.
Yeah, great to see you. That was awesome.
Oh, thanks for coming. I appreciate that.
Yeah, how you been?
Good.
That was really good.
Oh, thanks.
Yeah.
Thanks so much for coming. I appreciate it. Yeah.
So we'll talk next week.
We'll talk. Yeah. Thanks.
That's so good.
Yeah, thanks. You enjoyed it? That's
Yeah,
okay.
yeah, no, it was
I've
really.
been so nervous all week. I'm so
Oh,
glad
no,
that
you
it's
did
done.
great.
He didn't look nervous at all.
Yeah.
Those
Those are tough questions, but you're like piecing it right through.
I'm Jill
Kevin,
Oh,
Cooper.
yes,
nice to meet you.
yes.
One of the residents. Kevin, nice to meet you.
Kevin, one of the IM residents,
One of the
or?
PGY5s for allergy.
Oh,
We have
cool.
2.
Yeah, it's
Great.
the rest stuff.
Oh, Thank you.
How was that?
Busy. Yeah.
Yeah.
I need to actually go run and meet my buddy Daniel. He's also, do you know Daniel Marinescu? He's one of the new ILD hires at BGH.
Is he from Calgary or?
No. He just started within the past couple of
Yeah, I was
years.
so happy when I saw the Lung Center or the St. Paul's Division website and I saw you pop up. I was like, oh wow, it's awesome.
Yeah.
Yeah, we know each other from
From
undergrad.
undergrad,
Yeah.
living our little wee days.
Yeah, med school, residency,
Yeah.
pretty much. We actually fly the same plane, yeah. Except for the PhD, I didn't.
Yeah. Yeah, you didn't.
Yeah,
You weren't as masochistic as me.
Hey, now you're doing research.
Yeah. Well, when
let's
does
hang out.
Delina get back?
April.
In April,
Yeah,
okay.
yeah. So you can meet our little one.
Yeah, I'd love
Yeah,
to.
yeah.
I've seen freaked your photos on Instagram. She looks adorable.
She's lighting her heart.
What's her name again?
Renaya.
Renaya.
We call her Naya for short. Yeah. Yeah. No, we should hang out. Yeah.
Yeah, I'd love that. We should get dinner, or like go to the beach or something.
Yeah, let's
that's
do
warm
it.
enough.
Yeah. I say hi to Sean.
Yeah, I will. I'll
Yeah.
talk to you later.
Great to
bud.
see you again.
Yeah,
Bye.
you too.
Okay, so patient is back.
It's up to you. Do you think 15 minutes is enough? I just don't want you. I guess I feel bad you had to stay on Friday night, so I'll give you the choice if you wanna.
I don't think 15 will be enough.
Yeah.
If I finish early, I can transfer back. and
If you
see.
want, yeah, leave it up to
Otherwise,
you.
if there's any tele people that you want me to see, I'm happy to do that too.
Sorry, if there's any what?
Like if there's any phone calls you want to do.
Sure, yeah, I'll let
I
you
don't
know. Because this will probably take you maybe an hour. Or...
Yeah, I think so. Because the complexity is.
Definitely, yeah. Well, because I just feel like if you come with me now, then you have to come back, right? And then if you, 15 is just not enough, right? So you probably.
It's maybe a little longer than that, yeah.
Yeah.
Just to like wrap everything up because he's being started on every single thing to think of. Stress, I don't know, but
Yeah, well, I
I
mean,
think 15
is there a
would be-
rush?
apparently not right now. In germs already seen. I'm gonna try and be quick, but if not, I can transit over back.
Yeah, just let me know.
Yeah.
Should find my keys. Do you grab lunch? I thought it was supposed
Yeah.
to be lunch.
Eight.
You eat something? Okay.
Sorry.
No worries,
I'm gonna
man.
see
It's
him right
fine.
now.
Yeah, no, go see him. Take your time.